We will now move to House File 2607, Representative Finke. Since Representative Finke is not on the committee, the chair will move that House File 2607, the first engrossment, be laid over for possible inclusion in an omnibus. And I understand there is an author's amendment. Let me just make sure I have the right bill here. 2607, here we go. And we have the A7 amendment. Is your author's amendment, Representative Finke?
That's correct, Madam Chair.
All right, so the chair will move adoption of the A7 amendment to put the bill in the form that the author would like to discuss it. And so all in favor of adoption of the A7 amendment, please say aye.
Aye.
Opposed? Motion prevails. The amendment is adopted. And so Representative Finke, to your bill as amended.
Thank you, Chair Liebling and members, for the opportunity to present my bill. This being my first time in health, and for the record, my name is Lee Finke. My pronouns are she, her, hers, and I'm very grateful to bring HF2607. This is a bill that clarifies statutory coverage of gender-affirming care into law. It's the current practice that gender-affirming care is covered, and we want to make sure that all gaps are closed, and that's all that this bill does.
Very good. Thank you, Representative Finke. Could you just briefly tell us what the amendment did as well?
Yes, thank you. The amendment, and I believe that Representative Nadeau had an amendment similar to this today. I'm not sure if that's how it turned out, but it was a religious exemption amendment that codifies a standardized exemption policy for our healthcare coverages. It was adopted in the Senate, introduced by Senator Hoffman, accepted by Dibble, and was a unanimous support for this change.
Great. Okay. Thank you so much. Okay, we have a number of testifiers lined up to testify on the bill, and we've asked each of them to keep it very brief. So first, Kat Roan. Welcome to the committee.
Thank you, Chair Liebling and members of the committee. My name is Kat Roan. I'm the executive director for Outfront Minnesota, our state's largest LGBTQ advocacy organization. This is the issue that brought me into advocacy. When I had my first job out of college, the health insurance plan at my employer had a blanket exclusion on all gender identity related care. And instead of just accepting that, I walked down to the HR office and said, do you know this is here? And a year later, it was changed and that care was covered. I do this advocacy work because I don't want other folks to have that fight on an individual level. Minnesota has been, in large part, providing this care through a series of guidances through our various departments, and we believe that it should be codified into law so that there is clarity for folks seeking best practice healthcare about what they will receive wherever they go, whether they have a private insurance plan or a public plan. We strongly support this bill. Gender-affirming care is essential health care, and we believe that all folks who need it should have access. Thank you.
All right, thank you for your testimony. Ash Tifa. Welcome to the committee.
Thank you, Madam Chair. Thank you, members of the committee. My name is Ash Tifa. I use she and her pronouns. I am Legal Services Program Coordinator at Rainbow Health. A significant portion of what I do in the Rainbow Health Legal Program is identifying folks' barriers to gender-affirming care, identifying them, navigating them, and helping them access the care that they need. Minnesota has done a really great job at minimizing these barriers through these administrative guidances that go back to 2015 that established that Minnesota would deny any policy that prohibits medically necessary gender affirming care on the grounds that it could be construed as discrimination under Section 1557A of the Affordable Care Act and Minnesota Statute 363A17. So this is long established policy for nearly a decade. And what this bill is really trying to do is achieve the incorporation of longstanding administrative guidance into statutory law and provide even further clarity for patients, healthcare providers, insurance providers, and regulatory bodies. So everyone knows we're on the same page that medically necessary gender affirming care is a right that every Minnesotan has. Thank you.
All right, thank you for your testimony. Susan Ilg? Welcome to the committee.
Thank you. Hello, Chair Liebling and committee members. My name is Sue Illig, and I live in St. Paul. I oppose this legislation because the evidence base for transitioning minors is very poor. Before passing legislation like this bill, I'm asking you to commission a systematic review of the research literature regarding the safety and efficacy of medical transition for minors. Systematic reviews are the cornerstone of evidence-based medicine because they synthesize all of the available research and also examine the quality of research. In recent years, health authorities in Europe have performed systematic reviews of pediatric gender medicine. As a result, Finland's health authorities call the gender reassignment of minors an experimental practice. Swedish health authorities say the risks of treatment likely outweigh the benefits. And in England's NHS banned the use of puberty blockers last month. Even the medical associations that endorse medical transition treatments for minors acknowledge the evidence base is poor. The Endocrine Society documented that almost all of their recommendations for the treatment of adolescents are based on low-quality evidence. The World Professional Association for Transgender Health, also known as WPATH, admits that they don't know the long-term impacts of puberty blockers on bone mass, brain development, and sexual health. WPATH, the Endocrine Society, and the American Academy of Pediatrics all acknowledge that following puberty blockers with cross-sex hormones threatens patient fertility, and almost all children who take puberty blockers go on to cross-sex hormones. Please commission a systematic review of the evidence. If the sponsors of this bill are correct that these treatments are safe and beneficial, a systematic review will only strengthen their position. If European countries are correct that these treatments are experimental and dangerous, then kids are getting hurt. And I would sincerely hope that you would want to know that before passing this legislation. Thank you.
Thank you for your testimony. Rebecca Delahunt? Welcome to the committee.
Chair Liebling and members of the committee, my name is Rebecca Delahunt, and I work as the Director of Public Policy with Minnesota Family Council. HF2607 requires all physical and mental health plans offered by insurers who operate in Minnesota to not exclude what the bill authors call gender-affirming care, which the policy states must now be designated as medically necessary. Based on the language of this policy, one might assume that the medical community globally has consensus on this issue, but that's not the case. Last year, a Forbes reporter noted how longitudinal data collected and analyzed by public health authorities in Finland, Sweden, and England have concluded that the risk-benefit ratio of pharmaceutical and surgical interventions for youth in this way ranges from unknown to unfavorable. The reporter shared that Finland, Sweden, the UK, and Norway are shifting toward a less medicalized approach that addresses possible psychiatric comorbidities and explores developmental etiology, end quote. The WPATH files released on March 4th show how WPATH has misled the medical community, all while leading insurance companies and legislatures with its protocols. NHS, the health service of the UK, just banned puberty blockers except in the use of clinical trials on March 14th. In short, there is lack of consensus within the global medical community on how to treat minors, and the USA is behind our European neighbors in this understanding. In prior hearings, bill authors have stated that detransitioners will be covered through this bill, but I will note that so-called gender-affirming care was not created with the intent to help folks detransition. There's no WHO ICD-10 code for treating detransition. For detransitioners, the physical and mental impacts of cross-sex hormones and diverse surgeries are broad. This community should not be excluded from care. When we consider this division, forcing all insurers to pay for this is misguided, and forcing all state taxpayers to pay for so-called gender-affirming care is coercion. Children cannot give informed consent on treatment that alters or potentially removes their sexual or reproductive health. Thank you. I ask for a no vote.
Thanks for your testimony. Sam Nelson? Welcome to the committee.
Morning, Chair Liebling and members of the committee. I'm Sam Nelson, outside counsel for Minnesota Catholic Conference, the public policy voice of Catholics in Minnesota. I also advise many Catholic churches and religious schools throughout Minnesota regarding legal compliance and religious liberty. I can be brief as I came to ask for the religious liberty amendments that have now been included in this bill. So I want to thank this committee and Rep. Finke for including these important religious exemption provisions to ensure that religious employers are not required to pay for coverage and benefits that conflict with their deeply held beliefs. The exemption that's now been included helps ensure that this coverage mandate complies with U.S. Supreme Court cases such as Hobby Lobby and Little Sisters of the Poor. Including the religious liberty provisions provides predictability and uniformity for employers and employees and avoids potential litigation. So again, I want to thank you for including the religious exemption provisions which uphold Minnesota's values of respecting the diversity of beliefs and values in Minnesota. Thank you.
Thanks for your testimony. Gloria Marmolejo? Welcome to the committee.
Thank you. Good morning. I'm the mother of a teenager.
And please state your name, if
Yes.
you would.
I'm Gloria Marmolejo. Good morning. And I'm the mother of a teenager with gender dysphoria. I'm a U.S. citizen who has lived in Rochester for almost 30 years. And so thank you, Minnesota representatives, for all your work and for being here today. I want to clarify that my testimony is not tinted by any political affiliation or any organized religion or church. I'm not conservative. I'm not liberal. I'm not even an atheist. I do believe in God. I'm just a scientist, a counselor, and a very, very concerned mother about my child with gender dysphoria. And because of that, I have consulted a wide variety of resources that have been mentioned before in some of these testimonies. We probably all agree that gender dysphoria is a condition that needs to receive the same quality of care that any other condition, cancer, heart disease and whatnot. And that, unfortunately, this is where we might disagree, that we have been led to believe that the task is easy. We just have to follow the current standards of care, affirm people with gender dysphoria by using their preferred names and pronouns, and then give them easy access to puberty blockers, synthetic cross hormones, and cross-sex surgeries. Some of you may think that then our job today is to pass Bill HF2607 to require health insurance coverage for gender-affirming care. Then people with gender dysphoria will live happily ever after in our state, right? Well, unfortunately, this is a harmful myth. My child, my family, and multiple friends are being hurt by this system. My child used to be a very happy, confident, and academically skilled girl. Sadly, being a nerd and a second-generation immigrant wasn't considered very cool in middle school. So she experienced long-lasting bullying, exclusion, trauma, resulting in several mental health conditions. She secretly...
I'm going to have to ask you to wrap up your testimony, please.
Yes. She secretly sought refuge in social media and state parental controls. Out of the blue, she notified after being hospitalized that she was not my son. She was not my daughter, she was my son. Now, unfortunately, she has followed the chain, and has been in
Yeah,
testosterone for the
I
last
do have
6
to
months.
ask you to please wrap up your testimony.
Sure. My daughter has been damaged for the months that she has been on testosterone. This has interfered with her pre-existing psychiatric conditions, with her therapy. She has landed in the ER, and she has had to visit the hospital multiple times. The solution is not to approve health care for people with gender dysphoria that has not been found to be solidly grounded in empirical evidence. And my child is being a victim of this system.
Okay, thank you for your testimony.
Thank you.
Okay, is there anyone else in the room who wants to testify on the bill? All right, not seeing anyone, we will go to amendments. So there are several amendments filed. Let me see here. We have the A5 amendment. Is that, no, we're not offering the A5? Nadeau? Okay.
Thank you, Madam Chair. I want to be helpful. Thank you Representative Finke, for meeting with me yesterday, and so there's no surprises with what I'm doing. And so, Madam Chair and members, what this amendment does is, this amendment just ensures that if we pass this law, that medically necessary gender-affirming care also includes a transition. Thank you. Sorry about that. Detransitioning. And when we talked about this yesterday, Representative Finke assured me that the way that we look at this is transitioning is it is what it is in any way. So I do recognize that this might be comfort language. But I still think it's an important thing to try to put in the law so that it's fully clear and it's simple and it's understood, that if this moves forward, that it is full coverage. Thank you, Madam Chair.
Representative Finke.
Thank you, Chair Liebling and Representative Nadeau. I also appreciate the conversation that we had yesterday about this amendment. I'm going to ask members to vote against this amendment, and it's not because I don't appreciate the concern that's being brought. Detransition is a real thing. Gender-affirming care covers detransition. Even since our conversation, I had multiple conversations, and I know our testifier did as well, to ensure that that fact is true. And we don't want to interrupt anyone's necessary medication. I will just add that I'm prone to not add comfort language. I had carried a bill last year to remove some comfort language from 1993, and that at great personal cost. So I would like to avoid that. The bill covers what we're doing, and I think it's good.
All right, Representative Quam.
Thank you, Madam Chair. I feel that acknowledging gender fluidity is not unidirectional, should be plain language in the bill, and I'm shocked that we would not include this language. Thank you, Madam Chair.
Representative New Brindley.
Thank you, Madam Chair, and thank you, Representative Finke. I would hope that members of the committee will choose to vote their conscience on this. A lot of legislation was passed last session that was all comfort language. Frankly, the entire abortion issue that was litigated last session was effectively comfort language. Our Supreme Court has already established what that is, and guess what? The Minnesota State Supreme Court isn't changing their minds. So, there is a very good reason to include this kind of language and ensure that everyone is protected. And again, especially if we don't think that it alters the underlying bill and it doesn't alter the intent of the bill, it just makes sense to affirmatively say that we are going to ensure that everyone is taken care of. Thank you, Madam Chair. And Madam Chair, I'd request a roll call vote.
All right, roll call having been requested, there will be a roll call. Is there any more discussion? All right, seeing none, the clerk will take the roll on the A5 amendment. The chair votes no.
Chair Liebling, no. Vice Chair Bierman.
No.
Bierman, no. Lead Schumacher.
Schumacher, aye.
Schumacher, aye. Representative Acom.
No.
Acom, no. Representative Backer.
Backer votes aye.
Backer, aye. Representative Bonner.
No.
Bonner, no. Representative Carroll.
No.
Carroll, no. Representative Elkins.
No.
Elkins, no. Representative Fisher.
Fisher, no.
Fisher, no. Representative Hemmingson Yeager.
No.
Hemmingson Yeager, no. Representative Herb.
No.
Herb, no. Representative Keel.
Keel. Aye.
Keel, aye. Representative Murphy.
Yes.
Murphy, aye. Representative Nadeau. Aye. Nadeau, aye. Representative New Brindley.
Yes.
New Brindley, aye. Representative Perryman.
Perman, aye.
Perryman, aye. Representative Quam.
Yes.
Quam, aye. Representative Ryer.
No.
Ryer, no. Representative Smith.
No.
Smith, no.
There being 8 ayes and 11 nays, the motion does not prevail. The amendment is not adopted. Okay, we are now, there's an A6, and I assume that is withdrawn. Is that correct? That was the one that was the same as what was adopted or close to it.
Madam.
Representative Keel?
Yes, that is withdrawn.
Okay.
It is included in the A7.
Thank you. Okay, let's go to the A8, which is also Representative Nadeau.
Thank you, Madam Chair. This amendment, so, you know, we've moved quickly last session to establish Minnesota as a refuge for gender-affirming care, and other states are moving just as quickly in the opposite direction, and honestly, it's far too often about politics. And, you know, Minnesota has had this incredibly strong history of reviewing, evaluating treatments and policies, always searching to find that proper balance between benefits, patient safety, the cost, and the evidence to defend those decisions. If we're going to proceed down this path that provides medical transition treatments, I think long before we should be talking about whether or not health plans pay or whoever pays for the cost of care, I think we should be leading the nation by creating a commission that's charged with reviewing the research regarding the safety and efficacy of treatments for children, adolescents, and adults. I've just started trying to learn about this since last session, and I appreciate that. And I've learned that the prevalence of gender dysphoria, it's super difficult to determine. Recent studies show that between 0.4% and 0.6% of adults identify as transgender. Higher percentages now among adolescents, 1.2 to 4.1% of adolescents are reporting gender identity different from assigned at birth. And not all children and youth who report these gender identities different from those assigned at birth ever experience that persistent gender dysphoria that I think is what we're trying to really work on here. And the trajectory of gender dysphoria in children is different from that of gender dysphoria presenting in adolescents. And these, I think, are vital considerations that I think we need to be trying to address. Thankfully, the medical community has moved away from their previous consensus of viewing gender variance as a disease model and to an affirming one. It's continuing to adopt those practices, recognizing that there's minimal research and even less longitudinal research on adolescents. So in the last several years, based on the research that I've been working on, health authorities in those areas across the globe that are far ahead of us in this specialty have started questioning the pediatric medical transition treatments, and they're starting to rethink some of the things that were acceptable before. So, Madam Chair and Representative Finke, my A8 amendment, what I'm trying to do is I'm trying to protect gender-affirming care for adolescents by focusing those treatments and standards on care through counseling, through supportive psychotherapy that allow youth, families, care providers the opportunity in a supportive environment to care for youth, but preserving medical and surgical interventions until after the age of 21. And so that's what my A8 amendment does. It creates another definition of adolescent gender-affirming care that restricts medical and surgical treatments. So thank you, Madam Chair.
Okay, Representative Finke.
Thank you, Madam Chair, and Representative Nadeau for your amendment. Again, I appreciate the conversation. We had a really excellent conversation about this yesterday, and I believe you that you want to protect kids. You want to make sure that we are providing young people with necessary care that will be good for who they are for their whole life. And it's gender-affirming care only doesn't do that if you believe that gender-affirming care is not health care. If you believe that gender-affirming care is health care, then we understand that we need to provide medically necessary care to those who need it. You said it's often political when we get into these conversations. To avoid being political, I didn't print this, but I thought about it. In the last 3 years, Republican states in very overwhelming conservative states have passed bans on gender-affirming care for minors. And 3 of those states actually, the governors, the very, very conservative governors of those states vetoed that law. And they vetoed that because before they signed it, they did their work. Governors of Utah, Arkansas, and Ohio. And they met with families, and they met with doctors, and they met with trans kids, and they said, we should not do this. So I did not print the veto letter from the governor of Ohio, Mike DeWine, but I would encourage you to read it. I would encourage us to recognize that if this is health care, then it is families and doctors who should provide it, and it is families and doctors who should decide when, and it is not up to us. And I would just add that this amendment also, I'm not sure why, but it increases the age of the minor from 18 to 21. Other states are increasing it to 25. Other people are just going after adults. And we're seeing the scope creep of attacks against what, if you don't consider health care, you can do what you want, but this is life-affirming health care. Please vote no.
Thank you. All right, all in favor of the A8, you weren't on the list, Representative New Brindley. You hadn't raised your hand, and we are in the middle of a vote, so we're going to vote. All in favor of adoption of the A8 amendment, please say aye.
Aye.
All opposed? No. The motion does not prevail, and the amendment is not adopted. Members, if you want to be on the list, get on the list, and don't do it while we're voting.
Typically, we're asked if anybody wants to address the issue.
Well, you've been doing this a while, Representative New Brindley. Usually, you don't need to be invited.
Literally ask every day.
So let's see. We have disposed of the amendment. So is there any discussion to the bill as amended? Representative New Brindley.
Yes, I did not notice this actually in the A7, or I would have had an amendment to the amendment, unfortunately. But I just want to be clear, on lines 5.25 to 5.28, there is no cost sharing whatsoever for any of this treatment or procedures without respect to income limits or anything else.
Representative Finke.
I'm sorry, just to be clear, we're talking about the A7 amendment?
Correct.
On 525?
Correct.
Representative New Brindley, could you pull the mic toward you, please?
Yes, absolutely. Lines 5.25 to 5.28. Did you want me to repeat that point?
Representative New Brindley, why don't you go ahead and repeat it? Yeah.
Sure. I like I said, I missed this in the A7 and was just reviewing it. And I just want to make sure I'm clear that lines 5.25 to 5.28 would indicate that there is no cost sharing that is allowable, no co-payments, no co-insurance, nothing regardless of income or ability to pay.
Representative Finke?
Thank you, Chair Liebling and Representative. Yes, so I think that research has something on, is there something about this piece, or maybe one of our testifiers who were involved in the Senate side could describe how this language is working?
Ms. Clark-Fist?
Madam Chair and Representative New Brindley, this language on 5.25 to 5.28 only applies to coverage that's an accommodation for an eligible organization. This provides there's no cost sharing for coverage for enrollees under a health plan offered by an eligible organization that otherwise declines to provide this coverage. The general language of the gender affirming care bill would allow for cost sharing.
Okay, thank you.
Representative New Brindley?
Thank you.
Yeah, okay, thank you. Representative Quam?
Thank you, Madam Chair. Can the author tell me what specific scientific studies you used to, refine and do the background and do the language for this bill?
Representative Finke?
Thank you, Chair Liebling and Representative Quam. Yes, I used the research that was done by every major medical organization in the United States, as well as the WPATH internationally. There is no medical debate in America's medical associations about the necessary quality, medically necessary gender affirming care provisions. There is debate about it, but every major medical organization recognizes that gender affirming care is necessary life affirming health care and should be provided. I would also like to, if I may, take a moment and say that, we hear a lot about the Nordic countries and the Nordic countries changing their policies around gender affirming care, Nordic countries and UK, and we do not have time for a geopolitical analysis, but Southern European countries are going the other way. That's because we have been politicized. This is a political issue. Many people are hearing about us and debating us and deciding our decisions as though we have not been receiving gender affirming care. Gender affirming care has always existed, y'all. It's not new. It's not 3 years old. It's not 5 years old. It's been being provided in Minnesota for decades. The idea that you are learning about who we are is happening not because of a decision we made. It is a decision that was made by conservatives to politicize us for political gain. And I can show you that research too. They chose it, they threw everything at the wall, and trans kids stuck. So the research is there. The attack is not scientific. It is political, and we can show you the receipts.
Madam Chair?
Thank you. Representative Quam, follow.
Well, the answer, the author didn't give an answer. He dropped into a political diatribe, didn't note one
And
specific.
Representative Quam-
Madam Chair,
Representative Quam, excuse me, we need to use the correct pronouns, please.
okay, the author did not answer the question because the author gave no, how should we say, scientific study. He referenced general
Representative Quam,
discussions.
please
Ma'am,
use
can
the
I?
correct
I'm asking for
pronoun.
information.
I'm
I said the
asking-
author. I said the
No,
author. Okay,
no,
Madam Chair, let me go on. There was a testifier that made a slight error in the statement when they said that the UK allows clinical trials. The actual UK allows only approved, pre-approved clinical trials. But looking at actual scientific studies, like a 15-year-long longitudinal study over thousands of children that had gender confusion, they questioned their gender. The vast majority by the mid-20s no longer, that disappeared. And the scientific studies I've been looking at from multiple countries over multiple years have all indicated that there is no distinct and statistically significant indication of improvement from puberty blockers and the surgery when it comes into, in fact, there were control groups that looked at a controlled group and then outside, and there was no statistical difference for suicide and those issues. But there are in the studies issues where puberty blockers have caused health problems and conditions in later life. And there's a list of those I can send the author, since the author apparently is not familiar with the scientific studies, so and couldn't quote me any that the author utilized for the writing of this bill. And my whole point is when we make decisions, we should actually use science, not drop into diatribes about politics back and forth. And when I was young, Denmark and other countries were way ahead of procedures, and that was mainly focused on adults. And I think the main debate here is permanent life-changing procedures for children, adolescents, some pre-pubescent, and frankly, as a human race, we have had adults protecting children until they could make the decisions as an adult. So the whole debate should be based on scientific studies and should be based on long-term concern and care for children. I haven't heard anyone debating adult treatment, but permanent life-changing treatment to children has been something that we have been very cautious as a human race. That's why parents have the authority, medical authority over kids. Thank you, Madam Chair.
Thank you. And so we have 4 members on the list, and then, so we have Nadeau, Fisher, New Brindley, and Keel. And so I know there's a, okay, so Fisher, New Brindley, and Keel. But Representative Finke, if you would just, rather than, I don't know, I'm sure you want to respond, but rather than kind of go back and forth, if you could kind of make some notes, and then at the end, I'll give you an opportunity to wrap up and respond. I think that would be possibly the most efficient way to proceed here, if that's okay with you. So, Representative Fisher.
Thank you, Madam Chair, and thank you, Representative Finke, for bringing this bill forward. This is something that I've followed for many years. Having worked in the homeless youth world since 2007, a lot of the youth that we worked with were people who were dealing with gender dysphoria. And back at that time, I did a lot of self-education, taking a look at what does the science say at that time, what does the medical procedures say at that time, and everything, and this is going back to 2007, so this is not something that's been overnight or whatsoever. This is literature that I keep on going back to and referring to, that the procedures that are out there are very necessary, particularly when you're dealing with youth or people who've got extreme forms of gender dysphoria, that sometimes the only way they can prevent suicide is to go on to the next steps. And that's one of the things that I've seen over time, is that when youth have been able to come out as who they are, they thrive. When they aren't, the depression that they deal with and the lack of acceptance in society that they deal with is so horrible that sometimes they're driven to take matters into their own hands, and which usually ends up in suicide. So when we talk about this, this is basic health care. When I take a look, you've got an option between suicide or having procedures that will help make you who you are. I think that is gender affirming care. And the studies that I've seen over time reaffirm that. And this is going back over years. And so this is why I'm a strong supporter of this bill. It helps save lives.
Thank you, Representative Fisher. Representative New Brindley.
Thank you, Madam Chair. And I just need to address this idea that, the author just told everyone that that these objections are politically motivated by conservatives, and that needs to be addressed. I personally have done a lot of soul searching over the last few years about what my hierarchy of values includes. And as part of that, I supported the ban on conversion therapy last year because it occurred to me that parental rights was actually not the highest level of priority. Protecting kids was the highest level of priority. And so to suggest that our objections here are politically motivated, implying that they are somehow just mean-spirited and that we don't actually care about these issues deeply, is not just offensive, but it is wrong. And as Representative Quam said, I have not heard a single member of my caucus argue once against gender-affirming care for adults. And in fact, I've said very clearly, adults get to do what adults want to do, and they should live their best lives. I think it's a little funny that the other side of the aisle here passed age 21 for tobacco. Like kids up to age 21 can't possibly use tobacco, but it's perfectly okay for them to make permanent changes that cannot be reversed. Hormone therapy alone has permanent changes that can never be reversed, including sometimes that child will never experience an orgasm, not in their entire lives. That's the reality of this when this happens for children. Surgeries that can never be reversed. That's the reality of this. This is not political for us. We actually think that there is a great deal of potential harm for the children that I 100% believe you are trying to help. There's no doubt in my mind. I tell everyone, the people who serve in this legislature are good, decent people who are trying to do the right thing. We just disagree to orders of magnitude on what that is. But I certainly believe that your intention is to help children. Parents are told that their children are going to kill themselves if they don't do this. They're not told that their children are likely to be suicidal after they do this, which is in the data. So while we disagree on what the right thing is for these minors, don't you dare tell me that this is politically motivated. I have put my own reputation on the line. I will do it every time. I get it from both sides of the aisle, from Republicans and Democrats. They don't like my stand because, frankly, on these kinds of issues, parents shouldn't have the final say. We, as responsible adults and lawmakers, should have the welfare of children as our primary, above all else, moral compass. And this bill certainly does not do that.
All right, thank you. I'm going to go to Representative Keel, but I just want to remind everyone the bill is about coverage, insurance coverage. Representative Keel.
Thank you, Madam Chair. Representative Finke, I downloaded some information from the Journal of Clinical Endocrinology and Metabolism to research exactly what Representative New Brindley said. How do I know what's happening? How does it affect especially our children. And I think we need to make sure that we know the long-term effects. I wouldn't take my child to get an appendectomy that they need, or a tonsillectomy, or something that is just normal to do, if I thought it wasn't necessary. Or the other way around, the doctor explains, well, this is not this is a problem, and this child needs this done because they will die. And there's some really concerning information in this endocrinology report that leads back to 2009. So it's not recent, more recent, but my concern is, have you had chance to read this information and what it does to our underage 21 years and under, especially 18 and under? Have you been able to read that?
Representative Finke.
Thank you, Chair Liebling. I'm sure I have not read that endocrinology journal article that you found on the internet.
Representative Keel.
Thank you, Madam Chair. It is a journal that they put out from clinical, it's a journal of clinical endocrinology and metabolism. Can't even say that word. But my concern is that we're only looking for certain information to affirm what it is that we want to do. I understand the medical coverage in this. However, I would have real concerns about not knowing the detail of what I would be asked to pay for, much less take care of my child. And I would encourage you to read this because it has some really concerning issues as far as lifestyle of existence after those things are done, such as bone density, heart concerns. There are some real changes in what we're talking about doing to children that are especially prepubescent, but also, just have not gone through puberty and, mentally questioning who they are, much less physically deciding permanent changes. Like Representative New Brindley said, these are life challenging decisions, and our children need to understand what it is they're choosing, and their parents. So thank you, Madam Chair.
All right, thank you. Representative Ryer, and then we're going to go to Representative Finke to close up.
Thank you, Madam Chair. Thank you, Representative Finke. I appreciate your carrying this legislation and your advocacy. I want to note that parts of the conversation have been, this is not about adults. We want to support adults to live their best life, live who they are. And I want to remind us that harmful disregard of someone's preferred chosen pronouns directly conflicts with the message that we want to affirm people and let adults and encourage adults to live their best lives. Further, I want to say that gender-affirming care for all ages is a range of treatment. It's a range of choices they make, from the clothes, from name to hair, and yes, pronouns. And when we misuse pronouns, and when we intentionally or deliberately misuse them or choose not to be careful, we're sending messages to our kids also that we don't care how they're seeing the world, and we are willing to do them harm. And the very act of doing that is an act of disrespect and violence against people, regardless of who they are. I personally think that when we misgender people, and yes, I do it sometimes, it's a habit. I apologize, and I work to do better. And I would call on all of my colleagues to apologize when they misgender and resolve to do better.
Thank you, and I'm sorry, I missed Representative Smith, so last comment, Representative Smith, then we'll go to Representative Finke.
Sure. Thank you, Madam Chair. Thank you, Rep. Finke, for bringing this bill. And Representative Ryer said a couple things that I thought was important to highlight, that we are hearing some folks say that this is just a scientific discussion. And yet, even in the small window that we've been discussing this in this committee, we have heard one member refer to other operations as normal, reflecting that this is in some way abnormal, which it is not. One member refused to use correct pronouns, and when corrected, would still refuse to use them. The author's competency has been called into question time and time again, and I can assure you that she has done the research and has shown time and time again that she has done the research. And once again, as the chair rightly stated, this is a bill about medical coverage. We are not requiring anyone to get this operation. We are making sure that families have the option, that this is covered, that it is affordable, that it is accessible. We are not the ones, and when I say we, I mean Democrats, the DFL, people on this committee who are going to vote yes on this bill are not in the business of saying people cannot get a medical procedure. We want that option to be available to people.
We said that last year.
All right, thank you. Representative Finke, final word.
Thank you, Chair Liebling, and members for the spirited debate. I have a few comments I'd like to make in response to some of the testimony or some of the members, and then we'll just close out this conversation. First, you know, there are when you were doing medical research, people disagree. You know, I know that there are endocrinologists out there who are studying this. I also know that the Pediatric Endocrine Society, the Endocrine Society, and the American Academy of Endocrinology all believe that gender-affirming care is necessary health care and advise its administration to children as necessary. It's not because no one anywhere ever thinks we should ask questions. Of course we don't think that. We should not pretend like the people who do the science and make the decisions and understand the medical history and reasoning are behind this. I also want to say that to Representative Quam's point, you know, most people do not grow out of being trans. A recent study by the NCTE, the largest ever done, of 96,000 trans people in America, this just came out a couple weeks ago, it found that 95% of trans people are more satisfied with their lives after transition than they were before. Only 3% said that they were less satisfied. If you go to any healthcare arena and say 95% of your patients will be more satisfied with their life after their healthcare, that is an astonishing rate, an astonishing medical rate of success. We do not do this for other forms of healthcare. We do not ask an entire country to account for healthcare when that healthcare is overwhelmingly supported by the medical and individual patient world. We do not do this. We are doing this for other reasons. I don't know what they are, and it's not a personal attack on anyone. I will say that, you know, my experience here has probably been different in terms of how people are or are not good about what they disagree with. We can disagree about what it means to make policy, but this is not a question that I'm willing to entertain disagreement about whether or not trans people should have access to their care. I'm grateful to my colleagues who have lifted me up and lifted up the work that we have done this past year and a half. If you are not hearing anyone on your side talk about adult health care for trans people, I have some messages I can send you, some video clips I can send you that they are, in fact, on your side in this body coming for trans health care for adults. This is not hypothetical. We're just trying to live our lives. I hate this. I hate this. I don't want to do this. We never had to do this before, and now we have to sit here and do this because we wanted health care, and some people decided we shouldn't have it anymore. So please support the bill. We're already doing this. We don't, we don't even have surgeries in Minnesota under 18. Representative Quam said that parents should be over the medical control of their children. While I don't love that phrase, no gender affirming care in Minnesota is provided without parental consent. The things that you are saying aren't true. The things that we experience and report back are true because we live our own lives. Please support the bill.
Thank you very much, Representative Finke. With that, House File 2607, the first engrossment as amended, is laid over for possible inclusion in the omnibus. Thank you. Thank you to all the testifiers.